Asherman syndrome, where there is scarring within the uterine cavity involving the lining, can be a really difficult and frustrating diagnosis. I have treated many patients with Asherman syndrome quite successfully, but it isn't a one-size-fits-all approach, and every case can be different because everyone can have a different level of scarring in different locations affecting the uterine cavity. I think about treatment of Ashermans in two steps. The first step, naturally, we have to do a hysteroscopy and we have to lyse the adhesions and open up the cavity and try to restore normal volume and normal architecture to the uterine lining. The second step is don't spend too much time waiting for healing to happen, because the process of scar tissue formation is actually your body's way of trying to heal. That's what's happening. The fibroblasts are laying down scar, and you don't want to have too much time pass between when you have your surgery to remove the scar tissue and when you actually attempt your next transfer. So my first piece of advice is only do the hysteroscopy when you're prepared to actually move quite swiftly into your next transfer attempt. And when you finally do move into that next attempt, and I'm assuming we're talking about transfers, but obviously this could mean trying on your own. But if we're talking about transfers, we have to decide the right protocol to use to try and maximize lining thickness and to improve the delivery of the drugs that we're giving to stimulate the lining to the actual cells in the inner lining of the uterus. So I typically will recommend using a medicated approach. I know there's many different schools of thoughts on this, but unlike a cryo-natural approach in preparing for a frozen embryo transfer, with a medicated approach, you're not at the mercy of someone's ovulation. And, you can keep stimulating the lining and exposing someone to estrogen to thicken the lining for as long as you want, as long as the estrase suppresses the ovaries, which it usually does a good job of that. And so you have a bit of flexibility in terms of not feeling like you're rushed and that you're moving forward with the transfer just because someone's ready to ovulate before the lining looks ready. And when I use a medicated protocol, typically I'm going to start with oral and vaginal estrogen. And there's no right or wrong, but typically starting with a more aggressive stimulation of the lining with two forms of estrogen makes sense. Sometimes people will just start with oral estrogen and then bring the patient in for an ultrasound. And if the lining looks thin, as expected, then they'll add in a second form, but you could do oral and transdermal in the form of a patch, or oral and vaginal. I like vaginal estrogen because I feel like it's being delivered locally close to where we're actually trying to get an effect in the target tissue in the lining of the uterus. And so I typically will use that along with experimental measures like vaginal Viagra. It's not perfectly studied and, the data on it is mixed, but this is one way to try to vasodilate blood vessels and improve the delivery of the drug to the lining of the uterus. And I've seen it work well anecdotally. Also, vitamin E, L-arginine, these are supplements that are also similarly designed to try and improve blood flow to the uterus. And sometimes we'll even use baby aspirin with the same thought process. My last piece of advice is don't be too much of a perfectionist. Yes, every embryo transfer, every embryo is precious and we want to put our best foot forward. But we also have to be realistic and look at what is your personal best when it comes to lining thickness. If it's 6 millimeters and prior to this you could only get a 4 millimeter lining and there were always pockets of fluid and you could see the scar tissue that had reformed, and maybe you've done multiple hysteroscopies, because that is a very realistic outlook for a lot of people with Ashermans. They're going to sometimes have recurrence of scar tissue over time and need a second look hysteroscopy. But progressively, we often will see that the cavity keeps looking better and better and the lining keeps looking better and better over time. So sometimes this has to be done in steps and it takes patience, and it's not easy, but you have to trust the process. And also you have to go for your personal best so that you're not continually just canceling and never getting to a transfer. Once it looks as good as it's going to be, at a certain point, you just need to go for it and try. And I've had patients who, after many hysteroscopies and all of these interventions, established and experimental, they finally got to a lining thickness of 6 or even 5.5, and, we went for it. And sometimes it takes more transfers than the average patient because there is going to be residual scarring and not as much surface area in the uterine cavity to work with compared to the average case. But it can work and people can be successful. It's also important to make sure that you're talking to a high-risk OB, because a lot of women with Ashermans may be prone to certain pregnancy complications and they want to be monitored more carefully.